So these lovely children here are waiting for food distribution in Kenya that's made available in some areas for poorer families. And they're waiting with great dignity. They're all wearing masks, they're correctly socially distanced, and they're behaving perfectly. And of course, queuing and waiting patiently is actually quite hard when you're hungry. But this is what they're doing. Now, this is a protest in the Philippines against the new Nationality Act. And we see the great dignity with which the protesters are protesting. And we see that they're socially distanced. We see that they're disciplined. But they're still exercising their democratic right to protest in a dignified, safe way. They're outside, they're wearing masks, they're socially distanced. This is a safe demonstration. And the same here. This is another safe demonstration. So this young lady here is wearing a full protective visor. Everyone is wearing masks. Everyone's socially distanced as they make their political point. Welcome to this weekend's update. Now, there's so many things I'd like to talk about this morning. There's the increased cases in the United States. There's the frightening severity of severe cases in Yemen and how quickly individual patients seem to deteriorate. There's the growing tragic situation in Brazil and Peru with increasing cases. But unfortunately, you're looking at my team. I am the research team and the presentation team, and indeed very often the technical team. So I've got to be very selective about what I do. I just can't do everything. So what I've done today, and I want you to stick with this video. This is one of the more important videos I've made. Now, way back in January, I was talking about this pandemic, and I was talking about the 1918-19 pandemic. And of course, I got slammed for daring to compare these two pandemics. How dare I possibly say that this pandemic is similar to the 1918 pandemic, which of course killed upwards of 50 million people, maybe as much as 100 million people, no one's quite sure. And then I was slammed for saying it's a pandemic and causing fear and all sorts of things like that. But that doesn't bother me too much because unfortunately the things I predicted back in January, February are coming to pass now. And it's not that I'm any special powers, I just looked at the transmission characteristics of this virus. And there's something else that's now come to my attention based on the transmission characteristics of this virus that I want to share with you this morning. Now, we know about case fatality rate. So case fatality rate is the number of people that die related to the number of people that are diagnosed. And we've seen that this has been fairly high in some European countries. But we knew there was a lot of people that were undiagnosed, that weren't picking up in this statistic. So perhaps a more useful statistic is the infection fatality rate. And that is the number of people that die related to the number of people that are infected. And as we've seen, some countries that might have a case fatality rate of, say, 10% from the diagnosed cases end up having a case fatality rate of perhaps 0.8%. An infection fatality rate of 0.8%. So the infection fatality rate is way lower than the case fatality rate because this depends on diagnosis. But this depends on mystically knowing the number of people that are infected. And of course, we won't know this for sure until we have very universal antibody testing. So we know the infection fatality rate, the IFR, is lower. That's the first point to make. Now, what I wanted to look at now was a couple of studies that make predictions based on this infection fatality rate. Now, this is based on this study, predicted COVID-19 fatality rates, based on age, sex, comorbidities, and health system capacities. So what this study is, just before that, Centre for Global Development. Now this is an international think tank. It's based in the United States. It produces very high quality very well researched publications. It's funded by various governments and agencies around the world. For example, the Norwegian government recently gave it $5 million, such is its ability to do useful work. So that's what they're looking at. Now, by way of background here, we know, of course, that older people are more likely to die, younger people are less likely to die. We know that men are more likely to die than women. We know those with comorbidities. For example, from the South African data we looked at over the past couple of days, we saw that people with HIV are about 2.5 times more likely to die if they contract COVID-19. We saw that people with uncontrolled diabetes, unmanaged diabetes and high blood sugar levels were about 13 times more likely to die. We saw that people with high blood pressure were about 1.5 times more likely to die. These comorbidities. And some of these have been quantified to a fairly good extent. And we saw that in that very, very useful South African study yesterday from the Western Cape health authorities. So we know about these things, but we also know that perhaps 80% of people are going to get a relatively mild illness. So about 80% are going to get a fairly mild illness, the people that get that, or even be asymptomatic. About 15% of people are going to be quite poorly. They're going to get a more severe illness, but about 5% of people are going to be critical. And for these 5% of people that get critically ill, the quality of healthcare that they get will determine whether they live or they die. It is very simple, because they're going to need medical help to survive. So, for example, they're going to need oxygen therapy. They might need pressurized oxygen therapy, such as CPAP or ventilation. They might need intravenous fluids for their hydration. They might need intravenous antibiotics for their co-infection. They're going to need quite a bit of support. But these people are also going to need quite a bit of support as well, although they probably survive without the medical support, but a lot of these won't. And how well these people survive depends on the quality of the medical facilities. So we see that the likelihood of survival for any given infection depends on how old you are, what sex you are, what comorbidities you've got, and what access you have to healthcare. They're the 4 main factors determining your likelihood of dying or surviving. So how old you are, what sex you are, what comorbidities you have, and what access to healthcare you have. So this study was looking at that, taking that information into cognizance. Now, what they found was, when they looked at that the fatality rate from COVID-19 varies greatly across countries. Now, this is to be expected, because some countries have a younger demographic, therefore we would expect less people to die. Some countries have more old people, therefore we would expect more people to die compared to the number that are infected. Some countries have more comorbidities. For example, we looked at South Africa with over 8 million cases of HIV. So that's what we would expect. So we're going to look at that in some detail. But just before we go on to that, I wanted to look at this. Now, this is from the Lancet Global Health. And again, never take my word for these things. Always look them up for yourself. I always supply the full notes and the full references. And this is early estimates of the indirect effect of the COVID-19 pandemic. So we've just said that there's going to be these direct effects, people that are going to die as a result of the COVID-19. But this study, before we go on to look at the direct effects, is looking at the indirect effects. And I'm very keen we don't forget these indirect effects. So these are early estimates of the indirect effects of the COVID-19 pandemic on maternal and child mortality in low-income and middle-income countries, a modelling study. Now, of course, the whole process of pregnancy and delivery and the post-delivery period is replete with potential medical complications. And this is why there's a high mortality rate in areas with poorer healthcare facilities in this particular field. And this is a well-known problem throughout the world. I mean, there's so many things you could talk about here. One is the problem of what's called cephalopelvic disproportion, where the head, the cephala part, the head of the child is too big to fit through the opening in the pelvis of the mother because the mother was malnourished as a child. And that can lead to obstructed pregnancies and all sorts of horrendous problems if medical facilities are not available. But that's a slightly separate topic, maybe for another day. But these are indirect effects. Now, what we have is throughout the world, there's a relocation of healthcare resources in the developing world. Now, this is happening in my country as well, where people are behind on things like chemotherapy, and it's causing problems. But the relocation of healthcare resources in the developing world is a huge issue. And I've said right from the start of this pandemic that the people that are going to suffer most in this world are going to be the poorest people. Those in poorer, less developed countries are going to be the ones that are going to end up suffering most. And I still think that's true. And this is something I feel remarkably strongly about. The people in Africa and the people in poor parts of Asia and the poor people in South America, just because they might look different from us, just because the colour of their skin is different from ours, just because they speak a different language to us, just because they have a different culture to us, there's no way it influences their humanity. These people are 100% human, the same as we are. They are our brothers and sisters. All humans are very closely related, and yet these people are going to disproportionately die. And I just find it outrageous that we have whole groups of people around the world that are going to die just because they happen to live in a particular area or because they happen to be of a particular race. And huge numbers are going to die, and I'm going to give you evidence for that. And I'm just hoping that this video can go some way to preventing some of these deaths. So these reallocations are going on, and this could contribute indirectly to over 1 million additional child deaths. Right. Stalin said 1 death is a tragedy. At least he's reputed as saying 1 death is a tragedy. 1 million deaths is a statistic. And they're poor people in foreign countries anyway. You see, this is just terrible. This is human being babies we're talking about here. Each one of irreplaceable value. And yet 1 million of them could die from these indirect effects because of lack of resources. In addition to that, there could be 56,000 additional mothers could die. And of course the mothers are young women. For young people to die is a tragedy. The trouble is, in very many of these poorer areas, they can either spend their resources on maternal care or they can have an unmitigated pandemic, which is also not a good thing. So we need an urgent review of healthcare provision around the world. And really, actually, healthcare is actually quite cheap. You know, you can train up absolutely, I've done it myself, I've trained up absolutely brilliant nurses in various places. And it doesn't actually cost that much, and they can save lots and lots of lives every day. It doesn't actually cost that much. A lot of the basic things are quite simple. And yet the resources are simply not there for that. Meaning that people who just happen to be a different colour from me, just happen to be in a different country from me, just happen to be a different race from me, end up dying at massively increased rates, and it's just not acceptable. Now, getting back to the main thrust of today's lecture, or today's video, whatever you call it. Sorry, I gave lectures for 27 years. It's just bad habit. Do not intend to lecture you, I assure you. Infection fatality rate is difficult to quantify in many low and middle income countries. Now, why is infection fatality rate difficult to quantify? Well, it's difficult to quantify it in my country, in Western countries, never mind anywhere else. Now, part of it is non-random testing. Now, if we had random testing, that would be more representative and we could extrapolate into larger numbers, but we don't have the testing is not random, so non-random testing gives skewed biased data. Very many countries have incomplete vital registration systems, so we don't know who's sick. People could get sick and die, and the official statistics would never know about it. Estimate the adjustment to extrapolate estimates from infection fatality rate. Right. So this is saying it's difficult. This paper is saying it's difficult to estimate the adjustments required to extrapolate the estimates of infection fatality rates that we know about, such as we do know about in high-income countries. It's hard to extrapolate that to low-income areas. So just because the infection fatality rate is, say in my country, it's going to be, say, 0.8%, That doesn't mean to say it's going to be that in other countries. It could be higher, it could be lower. It's difficult to extrapolate. And that's the really clever thing about this study. Now, I've read this study, and it seems to me to be quite a superb study. And I don't pretend to understand it all. It's quite mathematical. There's mathematical models in place. I think I understood enough of it to get the gist of it and to realise it's a reliable study. So this is hard to do. It's hard to say, well, these are the figures in the UK, therefore this is what the figures will be in South Africa. That's hard to do, but the team are attempting to do that with some degree of success, I believe. So they account for differences in age, the differences in sex, and the differences in relative comorbidities, which of course we know are the main factors. We'll come on to the health services in a minute. These are grounded in fatality rates from countries with advanced healthcare systems. So the data we have is from countries with advanced healthcare systems, where of course we can treat the poorly people. So this paper tried to make adjustments to adjust for poor quality healthcare. So their adjustment reduces the demography-based advantage. Now what they're saying here is these poorer countries have got a younger demographic. There are more younger people because a lot of the older people have died already, which is another tragic story. Of course, they shouldn't have died already. They should still be enjoying their retirement, but they're not, they're dead. And that's for many other reasons. So it had been thought that the younger demographic in poorer countries would mean they have a lower infection fatality rate. But when they add in the effects of lack of healthcare, the adjustment reduces this demographic advantage. Now, this is where I want to give you some specific examples of this. Let's get rid of me. Right. So, for example, Sub-Saharan Africa, there's 1 billion people. Now, if they had the same death rate, taking into account age, sex, and comorbidities, then their infection fatality rate should be 11 in 1,000, 0.11. So in other words, for every 1,000 people that get infected, you would expect 11 to die based on the data from Western countries. 0.11%. But when they adjust that for the lack of healthcare, that jumps up to 0.43%. Because remember, 80% get mild illness, 15% get more severe illness, 5% get critical. And how many of these survive, or indeed if any of these survive, and how many of these survive, depends on the quality of healthcare. So if you take away good quality healthcare, many more of these will die. So using very advanced mathematics and clever modelling, they've worked out that in Sub-Saharan Africa, we can expect the infection fatality rate to be 0.43%. Pretty hard numbers. Latin America, South America, 430 million people. Now, given the demographic, given the comorbidities, given the age profile, the sex profile, we would expect the infection fatality rate in Latin America to be 0.39 if they had the same health facilities that we have in more advanced countries. That's what you would expect. But this data shows that's going to be much nearer 1% infection fatality rate. So 0.95 is going to be the infection fatality rate in Latin America. Much higher because of the lack of health provision. Eastern Europe, including parts of Russia, it should be 0.68, should be the infection fatality rate. You can see it's quite a bit higher than Sub-Saharan Africa, for example, because of the older demographic. So Eastern Europe, 209 million people, it should be 0.68%. But because they don't have access to the healthcare facilities that we have in Western countries, that should turn out to be 1.83%. Because of the older demographic, more people are going to die. So these are quite startling figures, really. Now, what I want to do now is actually run through a few real examples here. So I'm just going to give ourselves a bit more magnification if I can. Yeah, there we go. Let's get that out of the way. Now here's the first group. Now, Western Sub-Saharan Africa. Now, so this is countries like Nigeria, Ghana, Sierra Leone, Liberia would all be Western Sub-Saharan Africa. Now, this graph is very clever what this team have done. Now, this grey part, so first of all, the total height of these lines represent the demographic going from younger to older. So this is the number of people in the demographic. So we see there's more younger people there and many fewer older people there. So younger people, so I'm not quite sure it is 10, 20s, 30s, 40s, 50s, 60s, 70s, 80s, 90s. It's that kind of thing. In fact, I think that's what it is. So the height of that line shows the number of people in that demographic. This dark line at the top shows the number of people with comorbidities in that demographic. So as you would expect, as we get older, we see more people with comorbidities. So for example, if we look at southern sub-Saharan Africa here, we can see that quite clearly. So in the younger demographic, few people have comorbidities, but as we get into the older demographics, a much higher proportion of people have comorbidities, till here, and here it's more than 50% have comorbidities. So they're the things that are going to influence death primarily. And they've taken into account the male-female distribution here as well, of course. And what they work out for these Western Sub-Saharan countries is that the infection fatality rate should be around 1.1%. But when you adjust it for poor healthcare facilities, it's going to be 0.3%. Because based on this amount of, based on these comorbidities here, and based on these demographics here, they estimate that in this population 1.43% are going to get serious disease. So that's the number that are going to get severe disease, and of that 0.43% will probably die. So what I've done, just as an example here, I've taken these three sub-Saharan African countries. So this is this one's Eastern Sub-Sahara, so that's like Kenya, Tanzania, Uganda, Somalia, Eritrea. This one's Central Sub-Saharan Africa, so Chad, Sudan, Congo, Cameroon, South Sudan. So just taking those countries anyway, for example. Now, what that adds up to, if we add those three areas together, and we look at these overall figures. So this is the number of people we expect to get critical in these areas here. That's the number who will get critical. Normally they'd all be saved, but we can't save them all because we haven't got the healthcare facilities in these countries. So what that means is that's what the case fatality we would expect in that area. That's what it's adjusted for after we look at the lack of health facilities because of that number of severe cases. And it turns out there's 1,009. That's just over 1 billion people, 1,000 million people in that area. Now, this next bit is crucial to understand. If this disease carries on spreading, it will carry on spreading till 70 or 80% of the population are infected. Then there will be herd immunity. And I think we know that from previous videos. So what that means is 80% of this 1 billion people could get infected. And that works out at 807 million people could potentially catch this virus. And as we see, about 0.43, 0.44, so 0.43 of those end up dying. That would mean in this area 3.7 million people are going to die in this area of Sub-Saharan Africa. So just in the area of Sub-Saharan Africa, this data indicates there is the real possibility for 3.7 million people dying as a result of this pandemic. But let's go on down. So if we take this area here, southern Sub-Saharan Africa. Southern Sub-Saharan Africa here. Yeah. So again, that works out, if you actually work that out, South Africa and places like that. So this is the number of people there. There's 82.36 million people in this area. That number of people, 2.66 could become critically ill. 0.69% could be the adjusted infection and fatality rate because of the lack of access to healthcare services. And that would work out at, in this area alone, that would work out at 565,800. 565,000 people potentially dying in that area. South Asia here, so this is countries like India, Pakistan, Bangladesh, and we see there's already quite a lot of older people here, and there's quite a lot of pre-existing comorbidity that we see. Taking that into account, that means severe cases could be 2.33% of the population. That would give an adjusted infection fatality rate of 0.9%, which would mean that there could be 12.9 people, or 12.9 million people, that would potentially die in this area based on this data. Now, the other thing to bear in mind here is these figures are also going to depend on how quickly these cases occur. So we know this famous graph here now, don't we? We've looked at it many times. So we've got this graph here, and what this graph is okay, in the middle. So this is increasing number of cases here, and this is time along here. Now, the health services in most countries have an ability to cope with a certain number of cases. That's the number of cases the health services can cope with. So as our cases increased in the UK, we managed to keep the numbers down so the health services could cope, and now the number's going down. So that was the whole aim of this game. Now, hardly a game, that was the whole aim of this strategy. If we hadn't taken lockdown measures, then our numbers would have gone up more quickly like that. We would have had that sort of picture. But what we have in these poorer countries where there's limited health services is the numbers are going to go up, and even if the numbers go up slowly, they're still going to overwhelm the ability of their particular health services to cope. So obviously the number of cases that a poorer health service could cope with would be much lower. So those cases would be exceeded all the quicker, even if it was a relatively low number. So even if the numbers had been the same as they were in the UK, that line there, then their health authorities would still have been overwhelmed. But what is going to happen is that the cases are going to rise much more quickly than this. As we see, for example, in Brazil at the moment, it's going to take a while for them to go down. And remember, this line here is the ability of their health services to cope, that line there. So we can see they can cope with these people here, and they can cope with these people here if they can get into the hospitals. And we saw that tragic case just a couple of days ago on the video of a father who couldn't get into the hospital, but that means all of these cases here are going to be above the ability of their health services to cope in those particular countries. This is why we're looking at such large potential fatality rates. Now, going on to look at some other countries. So here, for example, we have Latin America. These are the Latin American countries. So we've got Latin America there. These three areas of Latin America. The way they've classified the countries here is a bit old-fashioned, actually, to tell you the truth, but we can work it out. So, for example, what we have here is these Latin American countries. So, where are we? Anyway, let's take these Latin American countries there. So if we take those Latin American countries there, so we've got 685 there, 62 there. Oh no, that's Asia, sorry. 62 million there, 258 million there, 219 million there. So those three countries there, that comes to a total of 539 million. 80% of that number, if 80% get infected, is 431 million, and that will give a fatality rate based on these figures here of. So there we see it's 0.92, there we see it's 0.97, there we see it's 1.02. So that's going to give us an infection fatality rate of about 4.2 million people. Now, we could go on here. We'll look at there's other countries we could look at. Do look up the data for yourself. We could go on. It is quite a horrendous picture, and it goes on to give details for other countries. But just before we finish, let's just look, for example, just to emphasise this point. Now, this is high-income North America, so that's the US, that's Canada. Relatively high-income countries, and we see that they're characterised by a much older demographic. So we have people, and this is the 90-plus group here. There's more people in that, but we see as people get older, there's a higher proportion of people with comorbidities, which of course is going to increase the potential case fatality rate. So the infection fatality rate, sorry. So the infection fatality rate there, given the conditions, we would expect to be 0.79% is the infection fatality rate. Now, of these, because of this demographic, we would expect 4.36% to be severe, only surviving if they had hospital care. Now, in many poorer countries, all of these lot would die, but here, after adjusting it for the good quality health services, we see that the infection fatality rate is exactly the same. It doesn't need to be adjusted because of the healthcare facility. Now, having said that, in 14 states in the United States at the moment, cases are rising very sharply, and we could have the problem where they go above the ability of the health services to cope. That is possible. They could go above the ability of the health services to cope, this sort of thing. So that's possible in the United States. And there's already cases. I mean, do look at that video that was sent to me by those grieving relatives the other day, yesterday or the day before. And I read a tragic case in the Guardian newspaper yesterday about a husband who couldn't get his ill wife into a hospital, and the wife and the child both died in New Delhi. So this is already happening in some places, and it's going to get worse. So. This is kind of well. Let me say, I just hope sincerely that I'm wrong about the way I've thought about this. But this is based on good quality data. It's based on good quality modelling, and it's certainly a significant fear, and it's not a ludicrous possibility unless we take global concerted action to improve healthcare provision in poorer parts of the world, which is currently now a global emergency. And we need to do this because at the moment you could argue that we have international structured racism in this world, where people of other races are simply allowed to die through simple lack of resources. And to me, it's an outrage against humanity. Now, on a slightly lighter note, force myself to go to a slightly lighter note. Yeah, so this is a company that sent me some information from South Africa, so they're getting ready for going back to work. Now, more of this later. We are looking at how we can get people back to work at the moment. They've got lots of infographics up on the walls there, which is excellent. They've got boundary lines where people aren't allowed to go. And the reason I put them on is because sycophantically they've given me some... let's just say they've given me some positive feedback. So thank you very much Thank you very much. I appreciate this. So here we've got the whole company that have gone back to work using the principles that we've discussed. And it looks like they're taking vitamin D as well. So couldn't resist that one, guys. Thank you. Good luck in your return to work. So I really appreciate it. It is, to be perfectly serious, to get this sort of feedback from places like South Africa is deeply humbling. So thank you. I really do appreciate it. It's great to know. Now, some of my favourite people. Who have we got today? Have we got the screen? Yes, we have. Good, good. So this is Alex, who watches in Estonia. And I don't think Alex is there, but he's got a clever video set. Oh, yes, he has. He's there. Bit dark, but thank you, Alex, for that. Thank you for watching in Estonia in the Baltic states. This is Alan, who watches in Indiana, over there in the United States. Maybe you'll give us a tune next time. That would be nice. So good to know you're watching, Alan. This is Brenda in Edmonton, Alberta. And that's the interview we did with that very clever New Zealand doctor, Matt, who told us all sorts of things about preventative medicine. Do catch that video if you didn't see it. It was quite enlightening. This is Carl in Palm Beach. Now, Carl listens on the earphones. So that's good to know, and we're glad to see he's getting some vitamin D, hopefully without being sunburned. But great picture, Carl. Thanks so much, and I am jealous of your walking circuit, my friend. Looks absolutely beautiful. Oh, this is Christine, who watches in Nova Scotia. So great to know you are watching, Christine in Nova Scotia. Now, I think I might be wrong here, so if I'm wrong, I apologise in advance. But I think the horse might be called Bob. If I'm wrong, apologies, Bob. But I know that's Christina watching in Nova Scotia, which is brilliant. This is Curtis watching in Santa Cruz. So great to know you're watching in Santa Cruz, and it looks like you're taking some interesting bits and bobs there. Thank you for the picture, Curtis. Great to know you're watching. Quite wonderful to see all these people around the world. Now, my apologies. I don't know your name. I've forgotten, but you'll recognise yourself, and your family and your friends will recognise you. But I do know you're in Orlando. This is what happens if I don't put the names properly on the files. Sorry, incompetence. But thank you for watching, sir, in Orlando. Delighted to know you're watching. This is Debbie and John in Oklahoma. Doesn't that look beautiful? Wow, look at the mountains. And I'm sure you're watching on the phone in Oklahoma. Thank you for that. Debbie and John in Oklahoma. You live in some beautiful places, you people. Deborah and Frank in Texas. Always good to know people are watching down south. Thank you, Deborah and Frank in Texas. This is Enna, who watches in Ireland, in the Republic of Ireland. John Campbell for president. Thanks for the offer. Might not take it up. Hang on, where we are. Second. There we go. Yeah, good. Thankfully, I'm not a politician. But thanks for sending that from the Republic of Ireland. Beautiful country if you ever get to go to Ireland. It's not called the Emerald Isle for nothing. Oh, this is Faris, who watches in Dubai. Now, is that still the world's tallest building? I forget what it's called now. Is it the Khalifa or something? Anyway, it might not be still the world's tallest building, but anyway, good to know you're watching, Faris, in Dubai.